If I speak from this distance, is my voice come through okay?
Yes, you sound just great, loud and clear.
Okay, good.
Great. All right, I think we can go ahead and get started. Welcome everyone to Geriatric Medicine Grand Rounds. I'm really glad all of you were able to join us. I know some folks are off on spring break with their kids this week, but I'm glad for all of those who are able to join us. We have quite a nice audience today. We have a really fantastic speaker, and I'm really glad that Dr. Ann McTiernan is joining us today. Her work is prolific and internationally known, and it's really just such an honor to have her here speaking with our division for Grand Rounds. So I'll tell you a little bit about her, and then I'll let her get going. So Dr. McTiernan is a professor at the Fred Hutchinson Cancer Research Center, but also a research professor at the University of Washington School of Medicine in gerontology and geriatric medicine, and in public health and epidemiology. And she has done a lot of wonderful research throughout her career, and is actively involved in many clinical trials and cohort studies with a main focus on how to prevent new or recurrent cancer with lifestyle factors, particularly exercise and diet and weight loss. So and I could go on for about 20 minutes with all of the wonderful things that she's done, but I'm really excited to hear your talk today for all of us on this topic. So thank you for joining us.
Thank you, and thanks so much for inviting me. I'm really pleased to be able to talk with this group. People in the older ages have a high risk of developing cancer and will want to know what they can do to reduce their risk. And in the past, clinicians often thought of cancer prevention as being ordering the screening test and sending the patient for screening. But there's much more than that. And much of what I'll talk about today is going to sound familiar for when you talk with patients about reducing the risk for other diseases like diabetes and cardiovascular disease. So you can give one message to people, or one set of messages that will go across their health span. So today I'm going to talk about weight, physical activity, and cancer prevention. I'm going to see if I can. I got it. Okay. I'm going to present some information about body mass and cancer risk. I'll talk about the physical activity and cancer risk. Talk a little bit about mechanisms, showing you one study that I was PI.
Sorry, find this. I can't mute my computer.
Say it again. Okay. And then talk a little bit about future research needs and conclusions. And in the beginning, when I talk about body mass, I'm going to show results of meta-analyses. And so, since not everybody in the audience does epidemiology or reviews epidemiology, I'll go over what I'm showing you a little bit. And then when I talk about exercise, I'm going to show results from the U.S. Physical Activity Guidelines Advisory Committee that I was a member of. And then talk a little bit about what they are recommending for cancer risk reduction. And then I'll talk about one trial. So first I'll talk about this meta-analyses. So there are different ways to measure body mass. As you know, none of them are perfect. Body mass index was developed for a different type of human than a lot of our the geriatric patients. that it was developed for young men. But it's still a relatively good measure in that it really, it pops up when you're looking at it in populations. So people that have higher body mass index have increased risk for certain diseases. People with very low body mass index have increased risk for others. And as a person ages, of course, their height is decreasing, their weight may be stable. That's going to put them into a higher body mass index category. Is that valid or not? We don't know, but it does show up in epidemiology studies as being important. And that's what most studies have measured. Waist circumference is a good measure of fat in the abdominal area, which correlates very highly with overall body fat, but it's not the whole story. We can look at weight gain and weight loss, and I'll show those a little bit in epidemiology. There's not that much have been done in those two, using those two types of variables. So first, this is called a forest plot. And what I'd like you to do is just look at the overall pattern as I go through. I'll go through a few of these for different cancers. And so look at the forest, don't look at the trees. With the exception, I'll point you each time we look at one of these down here. It's a summary statistic. And so look for the diamond when I put up a forest plot. And what this is this represents results from all the studies, all the epidemiologic studies that have looked at this particular issue up to a period of time. And there's a group in Europe called the World Cancer Research Fund that I was pleased to work with for many years on doing these types of meta-analyses. So these are results, statistics from epidemiologic studies that are added together into one large summary. So each of these studies refers to an epidemiology study. In these were cohort studies where women, in this case, it's breast cancer, women were either measured for height and weight or they were asked their height and weight. And then they were followed over time to see who developed disease. So each of these little tiny dots here refers to what's a relative risk. So that's the risk of cancer in those in a particular height and weight category, in this case, body mass index, compared to those in a lower category. And for many of these analyses, the particular studies had different ways of categorizing height and weight, or categorizing body mass index. And so doing a meta-analysis, all you can do really is look at like the top versus the bottom, because the cut points don't match exactly. And what that does, it makes the final result less precise, less strong. So every time I show you a summary relative risk, you can think it's probably a greater effect than what I'm seeing here. So this is body mass index and risk of postmenopausal breast cancer. Because this is a geriatric oriented audience, I'm not going to talk about cancers in young individuals. But you can see right here, this little diamond at the bottom is telling us that the relative risk for people in the highest category of body mass index versus the lowest was 1.12. In this particular analysis that we did it according to how much an increase in body mass index was. So in this particular analysis, this was per 5 units increase in body mass index. And so that's for a person going from body mass index of 25 to 30, for example. So this is a relative risk of 1.12 and statistically significant. If you wanted to ask what about increase of 10 points in body mass index, you just multiply 1.12 by itself. So we see that the body mass index matters for postmenopausal breast cancer. What about waist circumference? Not all the studies have waist circumference. Some of these studies, as I mentioned before, they were measured, and some the individual reported. And so those studies where patients or individuals were measured, you have more confidence that in their and the validity of that measure, because if you can imagine how people are at reporting their height and at their weight. And for many people that are asked in these studies, the people join those studies when they're in their 40s to 60s, depending on the study. And if they were asked their height, they might be reporting what they were as a younger person, or they might not really know. They might guess. Their weight also, they may be reporting what they thought they weighed a few years ago, or what they wish they weighed. So the studies that had the weights measured are thought to have more validity. And many people don't know what their waist circumference is. So these studies tend to be from those cohort studies where waist circumference was measured. So you can see that as the waist circumference on average increases, so does the relative risk of developing postmenopausal breast cancer. In this case, it's 1.35. So that refers to a 35% increase in risk of breast cancer. What about weight gain? Again, not too many studies have been able to do that, because in order to have weight gain data, you're either measuring people at different points in time, or you're asking them, what did you weigh when you were, say, 15 or 30 years old? And so that, again, is going to reduce the accuracy of that data, because there's some variability, first of all, in what the person recalls, but then also the age that you're asking them to remember, or how often somebody was measured in a study. But overall, we see some striking increases. So those people who gained weight over time, and this is a category of 30 or more kilograms, and unfortunately in our obesogenic world, that's not that uncommon, they have a 50% increased chance of developing breast cancer. What about weight loss? And this is the only cancer for which I'll be able to share data on weight loss, because as you can imagine, most people over time do not lose weight. And I know that you're dealing with a geriatric population, and some of those may be losing weight, but in the general population of individuals followed for these cohorts, they're not losing weight. And if they are, it's not purposeful. But there is some evidence that that those people, look down here at this part of the forest plot, this is postmenopausal women, those people who have lost weight over time have a decreased risk, about a 10% decrease in risk. And what you can see over here, just if you're eyeballing this, that each study had a different definition of what they considered weight loss, or what they compared for high versus low level of weight loss. So again, it's murky, but you're getting a signal that there's something going on there. This is not a clinical trial, it's an observational study. Well, going through different types of cancer. So there are quite a few cancers that are thought to be obesity related, and that's because of these types of studies, cohort studies that have asked or measured people's height and weight, and then followed them over time to see who develops cancer. Now, this can be done with a case control study, but this also, these studies that are in this particular set of meta-analyses are all cohort studies. So for esophageal cancer, and this is adenocarcinoma, not squamous cell, they're different cancers in terms of risk factors, but looking at adenocarcinoma, we see this relative risk for those, for each 5 kilogram per meter increase, each unit of BMI, 5 units of BMI increase is almost a 50% increase in risk of developing that type of cancer. And this is in both men and women. What about increase in waist circumference? So you see there's only 2 studies in that analysis. There are only 2 available, but it also shows the same trend as BMI, 34% increase for each 10 centimeters increase in waist circumference. Pancreatic cancer is also thought to be an obesity-related cancer. And as you can see, for each 5 unit increase in body mass index, of about a 10% increase in risk of pancreatic cancer, So again, if you wanted to know what's the risk for a 10-unit increase in body mass index, you multiply 1.1 times 1.1. And this just shows this in a graphic form. So for pancreatic cancer, you can see that those people whose body mass index are at the very high level have quite an increase. But this unit increase is about, it can get up to 50% increase. Again, pancreatic cancer, looking at waist circumference, looks like a similar trend that for every 10 centimeters increase, about 11% increased risk of pancreatic cancer. Liver cancer, another one that is showing up as it being obesity related. In addition, and I know you're thinking about other risk factors, but this is just an overall risk factor, so it's not competing with the other known risk factors like hepatitis viruses, but this is showing up in the data as being relevant. So for each 5-unit increase in body mass index, you see an increase of about 30% risk of liver cancer. And again, in graphic form, you can really see that at the very highest levels of body mass index, that's where you're getting the largest effect. Colon and rectum, often in epidemiologic studies, the colon and rectal cancers are combined because rectal cancer is much less common. It then does wash out some effect because rectal cancer is less related to either obesity or physical activity. But these are what the data are. And so you can see about a 5% increased risk for colorectal cancer. Sorry about that. For each 5-unit increase. This slide also combines men and women, and you do see more of an increased risk in men if you're looking at just men. But for simplicity, since I'm going over so many cancers, I didn't want to do too many subsets. And again, looking at those individuals as the body mass index increases, you do see a dose response. More increase in body mass index, greater risk of developing colorectal cancer. And the same thing for waist circumference. It looks a little less clear here. Part of that is because men and women are combined. Endometrial cancer is another obesity-related cancer. And you're going to see a really more striking association here. For every 5 units increase in body mass index, about a 50% increase risk of endometrial cancer. And some of these studies were begun, the cohorts were started when women were still taking hormone replacement therapy. And so these studies are all adjusted for that variable. And of course, now as women are getting older, they're getting further away from when hormone replacement therapy was common. Obesity is becoming a much more important risk factor for a larger proportion of patients with endometrial cancer. Again, you see a very striking increase. And so when I showed you graphs before, the other cancers, it was really, the units of measure were much smaller. But here, the units for relative, these are relative risks. You can see it goes up to 10 times higher for individuals who have a body mass index of 40. So it's very strong risk for endometrial cancer. Waist circumference shows the same sort of trend. And then looking to kidney cancer, we see for every 5 units increase of about a 30% increase in risk of developing kidney cancer. Waist circumference shows about 11% increase for every 10 units increase, 10 centimeters increase in waist. And then I think this is the last forest plot, looking at stomach cancer, the cardia. This is the part of the stomach that has similar cancer risks to esophageal adenoma carcinoma because of the cell types that are there. And sure enough, you can see, similar to the esophageal adenocarcinoma, you see an increased risk for this type of stomach cancer with increasing body mass index. So there's some limitations. I mentioned a few as we went along, that most studies assessed height and weight at the study entry without updating. So we know the effect of body mass index at somebody in the middle ages and what effect is that going to have on cancer risk in the older ages, but we don't know as much. There's some individual cohorts that focused on patients, the individuals that were older when they entered the study, like the Women's Health Initiative. They were 50 to 79 when they entered. The AARP study, individuals had to be over age 50 to be in AARP at that point. And so a few other studies, but many of them people entered the study when they were much younger. Many of the US-based studies use self-report height and weight, but the Women's Health Initiative used measured height and weight. And the European studies and Japanese studies tended to be measured. The issue of weight loss in cohort studies is very difficult to determine, as I mentioned earlier, because not many people lose weight intentionally over time. So the effect of weight loss on cancer risk really has not been established. And very few studies have measures of more specific body mass measures, such as DEXA, CT, and MRI for fat mass, fat distribution, or lean or skeletal mass, and those risks with cancer. So in summary, for body mass and cancer risk, increased risk for various cancers that I mentioned. There are some additional ones. There were not enough cancers or not enough studies to do meta-analyses, but at looking at the research overall, there's several other cancers that also have increased risk with obesity. And that I just summarized these statements before. So I can turn to physical activity, or I can ask if there's any questions on obesity before I go on to physical activity. Doesn't sound like there are. Okay, so I'll go on to physical activity. So the US Department of Health and Human Services does the dietary guidelines that many of you may have heard about or your patients ask you about, and those are every 5 years. But it also does physical activity guidelines. The first one was in 2008, and the second one is 2018. And I was honored to be able to join both of those, and led the working groups on cancer risk. And so when we met together as a body, one of the questions that we were asking for cancer is, what is the relationship between physical activity and invasive cancer incidence? We asked, is there a dose response? Is there a difference by gender, by race or ethnicity? Does it affect specific cancer subtypes? And what about persons at high risk for cancer? So overall, the Physical Activity Guidelines Committee also wanted to look at the elderly population, and that would be considered a group at high risk for cancer. So what we did was we did a systematic literature research. We got some help from a contractor, but then we did our own. And what we included was primarily systematic reviews and meta-analyses. So just like what I presented for body mass index, we did the same for physical activity and cancer risk. We looked at pooled analyses and source papers. We looked at randomized clinical trials. Unfortunately, there's never been a randomized clinical trial looking at exercise effect on incidence of cancer.
Now entering Wesley, doors to my right.
We also looked at prospective case cohort studies and case control studies. And what we found overall is that we found 45 systematic reviews of meta-analyses that included millions of people from around the world. We saw that most of those were conducted in the US and Europe and a few in Asia. that physical activity was measured almost only by a self-report in different ways, and different studies had different ways of asking people what they were doing and how much they were doing. But most of the physical activity referred to recreational physical activity and total physical activity. So as you're thinking about this, you might be realizing that these are kind of like, these are specific types of populations that are going to have access to, know about, and have availability of time to do recreation physical activity, and then add that into total physical activity. So we don't know about other types of activity, like the daily activity that somebody in a specific culture may be doing. They may be moving their body all day long, but we don't know what effect that has on cancer. Some of the studies were able to provide data on MET hours per week. So MET is a measure of how much energy is expended in a particular activity. And then using this variable that then can be compared across studies. And just like I mentioned with weight studies, the cut point for highest versus lowest level can vary across studies. It did vary across studies. And so that muddies the water a little bit and makes the effect size closer to none. And so that underestimates any protective effect we may see. So overall, what we saw was that we reviewed those data. We came up with this evidence grading. Some of you may have heard of GRADE as a method of grading evidence across studies. Various bodies that do this, like the US Preventive Task Force, uses a grading system. Cochrane uses a grading system. And for physical activity, our overall group developed a grade system that was similar to those, but that was specific to physical activity. If a grade is strong, it doesn't mean that there's a strong effect. It just means the evidence was very good, or as good as we could get. And then I put in evidence of how much risk reduction was seen overall for that cancer in people that the highest versus the lowest level of physical activity. And then the question, is there a dose response? Do you get better effect if you exercise more, have more recreational or total physical activity, or not? And what's the evidence for that? And so you can see there's a lot of cancers where we decided there was strong evidence that highest level of physical activity is associated with reduced risk of that cancer. And so you can see a lot of these are the obesity-related cancers I just talked about. But these are breast, colon, endometrial, esophageal adenocarcinoma, stomach cancer, bladder, kidney, with reductions ranging from about 12% to 20%. Some of the studies had evidence of dose response, but not all. But at least in a couple, two of the most common cancers, we saw strong evidence of a dose response effect. And then for some cancers, we had limited or no information. Overall, we also looked at sedentary behaviors. And so there's more interest in the physical activity research community, and not only looking at how active somebody is, but how sedentary they are. And there's a question, if you increase your physical activity, can you counteract effects of sedentary behavior? So you're sitting on the couch all day, you get up to walk for half an hour. Is that really enough? Is that going to overcome the effect of a very sedentary lifestyle? Particularly important in the geriatric population as they become more sedentary. But unfortunately, there wasn't enough information to answer that question. But we did find that there was moderate evidence that sedentary behavior was associated with increased risk for several cancers, and I've listed them there. So I'm just giving you the summary, and this is a lot of words to read, so don't worry about that too much. But they did focus on what are key guidelines. So when we did our report, our physical activity guidelines report, then the government takes that and puts that into guidelines. And the key guidelines for adults were what I underlined here: move more, sit less, exercise at least 150 minutes a week, up to 300 if you can, or more, of moderate intensity exercise. If you do intense, vigorous, you get more benefit with less time. And that also muscle strengthening activity should be done 2 times a week. But they also came up with guidelines for older adults. And so I've just pasted these right from the guidelines because I didn't want to change what they wrote, but I've underlined what I thought is most useful is that the same for older adults, do the same thing as younger adults if you can, but also they added in balance training. So it's not cancer related, but it's important for their lives, of course, and reducing risk of falls and other injuries. And that they made a statement that said older adults should determine their level of effort for physical activity relative to their level of fitness. And that's going to be important not only for the older adult thinking of that, but also for the clinician and team that are working with them. And in general, to be as physically active as their abilities and condition allow. And that's kind of a murky statement, but that's all that a government could do without getting very specific about different types of populations. Before I start on this, I just want to mention all of these studies have a major limitation. The epidemiology studies of both obesity and physical activity, in that most of those studies were conducted in white populations. There were some studies well done in Asia, but in terms of the US studies, they tend to be predominantly white, with some exceptions. And in the European studies, they tend to be a white population. So we know very little about people from various race and ethnic backgrounds that are relevant to Black, Latino populations. So now I'm going to turn to talking a little bit about what could be the mechanism associating adiposity, physical activity, and cancer risk. So this just very simple slide. I mean, there are a lot of arrows here, but if you think of increased adiposity and decreased physical activity, these are some of the pathways we're thinking. And you're not surprised to see increased insulin there. Sorry. And increased glucose, but those are relevant to cancer too, because insulin can be a cancer growth promoter. Certainly seeing changes in estrogen. So women and men who have a lot of adipose tissue will make excessive amount of estrogens, and that's very relevant for breast cancer and endometrial cancer. They can have altered androgens also, and for women, they'll have increased androgens, which then can convert to increased estrogens. There's some evidence that increased adipose tissue is associated with increased angiogenesis, and that's a growth of blood vessels, which are important for cancer progression. And then various other types of measures here. And I'll show some results from a clinical trial where we're testing if you get somebody whose body mass index is at a certain level, or who is physically inactive, you get them to change that behavior or to lose weight. What effect will it have on some of these, what we call biomarkers of cancer? So I'll talk about a trial that we conducted here in Seattle, and the goal was to look at the individual and combined effects of a 12-month dietary weight loss and exercise intervention, so either individually or together, on the following in postmenopausal women. And you recognize some of these hormones and biomarkers from the chart that I presented before. but we're interested in to see, can you change the levels of these hormones in postmenopausal women? So we know that women who have high levels of adipose tissue can have high levels of estrogens. Most common in postmenopausal women is estrone. The most active is thought to be estradiol. But some of these women, we measure them, they can have blood estrogen levels that are as high as a premenopausal woman, just simply because of what they're making in that fat tissue. So these are our main biomarkers in that trial. As I said, it was a randomized controlled trial. It was 12 months duration. We randomly assigned 438 women in the study. They were postmenopausal to join, 50 to 75 years old. Their body mass index had to be over 25. And they had to be insufficiently active. In Seattle, it's a little hard to find somebody who's interested in a study but is completely inactive. So we had people who were less active than what we wanted to see at the end of the study if they were in the exercise arm. And then they couldn't be using hormones and not smoking or drinking more than 2 drinks of alcohol. And that's because we didn't want to interfere with our biomarker endpoints. So these women were randomly assigned to one of 3 interventions: dietary weight loss, diet plus an exercise program, or an exercise program only, and compared to a control group. There are different numbers in each. By design, the controls were smaller in number. The exercise intervention is one we had used in other studies previously. We had them come in for 3 days a week to our facility, or work out at home 2 days a week. And work out at home. The goal was 45 minutes a day. Overall, the women met 80% of that goal of 225 minutes. The weight loss program, many of you who've been familiar with the diabetes prevention program, a look ahead diet, it was based on that. We used the same dietary goals, but we delivered it more in group sessions. And so the goal was 10% weight loss by 6 months, and we did that through calorie reduction. And we had individual plus group meetings, and the participants attended an average of 91% of their goal sessions. On average, baseline, the women were 58 years old, and about 30% were over age 60. They tended to be non-Hispanic white. Their body mass index on average was 31. We did DEXA scan on everybody, and on average it was 48%. We tested aerobic fitness, and their average aerobic fitness showed us that they were quite unfit. And we were lucky that we lost a small number of people by 12 months. Only 9% lost to follow-up. So what happened in this trial? We found what we're expecting, about a 10% weight loss with the diet, whereas essentially no weight loss in controls and very little in exercise. Looking at these various hormone endpoints, and I'll go through these kind of quickly because they look they have very similar results, but we did see on average overall that a weight loss program that with a goal is 10% weight loss, we saw decreases in our various endpoints in these hormones. So for estrone, the most common estrogen in postmenopausal women, estradiol, so decreasing. These are the interventions: diet and diet plus exercise, exercise and control. Testosterone went down, particularly in the diet and exercise group. And then what about amount of weight loss? For those individuals who lost weight, over 5% is where we see the greatest decrease in these hormones. Insulin decreased, no surprise. This has been shown in many other studies, but we were the first to look at estrogen effects of weight loss. And inflammation is an interesting biomarker for cancer, because so many cancers are increased in risk due to inflammation. Inflammation thought to be either an initiator or growth progression. We saw a 40% reduction in C-reactive protein in individuals who were in the diet plus exercise program. So really large change. I'm not sure if the slides will be available to the group afterwards, but I don't want to go to each of these because I've already, I don't want to run out of time, but the slides are here if anybody is interested. If they're not available, I can send them. So we looked at a lot of other biomarkers using other study data and found results in some, but not others. We then looked at a subset of individuals long-term, so 30 months after the being randomized. And what we found was that continued reduction in insulin and in some other markers, including increased sex hormone binding globulin, which then binds estrogen, so making it less available. Because this is a geriatric oriented audience, I just wanted to talk a little bit about side effects, adverse effects. We did look at lean mass change, and we saw diet alone did decrease lean mass, especially in those over age 60. Diet added with exercise added had less effect. Looking at bone mineral density, now this is overall bone mineral density. We didn't have specific measures for spine and hip the way you would clinically, but we did see something that's a little concerning, that in our control group, we saw no change in bone mineral density over 1 year. So it's just a 1 year period. A little bit in exercise, and we saw much more in the diet plus exercise. These people did lose more weight in general than people in the diet only. And then musculoskeletal injuries, so we asked everybody at the end of the study or during the whole study about reports of injuries. So this is everything. It doesn't, they could have just been feeling uncomfortable with some pain, but so we reported it all as one variable. And we see the exercise program, you just see more reported musculoskeletal injuries, but for the diet only and the diet plus exercise, it's actually less than in the control group. So ongoing research, we're continuing to use stored samples from these studies and look at exercise effects on various other biomarkers. We're looking at weight loss patterns. And then one ongoing trial is looking at the acute effects of exercise on breast cancer biomarkers and blood and adipose. And now we're looking at muscle tissue as well. Since we're getting late in time, I don't want to spend too much time on research needs, but we need more information, particularly from trials, I believe, because trials are going to be able to show us what's happening in terms of benefits against biomarkers of cancer risk, but also what are the detriments? Are there any increased risks for the population that would counteract overall benefit? Because certainly we're looking at cancer risk, but we also don't want to be increasing risk of adverse events in our patients. And we need much more information for both epidemiologic studies and for clinical trials in people from diverse race and ethnicities, from people at different age groups, and people who are at high risk of cancers for whatever reason. So overall, we see that increased body mass increases risk for several cancers. High levels of physical activity decrease risk. That the human experimental studies, and I've just showed you one, but there are quite a few that are completed both at our center and around the world, that there are biological effects of both weight loss and physical activity that are relevant to cancer. We have seen that this dose response effects are showed it very strongly in the cancer and obesity associations, but also in physical activity. And that there may be long-term effects to benefits. So somebody's physically active in the middle years, that may have long-term effects into their older years.
Thank you. And
So-
I have a question, sorry, just before, like, about the dose. There's a question in the chat from Kay Ritchie about information on the dose of physical activity. If you could just comment on that again.
Yeah, so I gave an overall from the US physical activity guidelines and didn't talk so much about dose. But the overall guidelines that says to be physically active 150 minutes a week, but that you get much more benefit at 300 minutes a week. We definitely see this in the cancer studies overall. In 45 minutes, I couldn't cover that, but you do see, but most of the studies are focused for cancer only on aerobic. And most studies, when you're asking people what they're doing in the middle years, mostly they're walking. So the data come from how much people are walking in general, how many minutes a week they're walking. And so we don't have a great deal of information about vigorous activity for cancer unless the people were in their younger ages when they were asked. So it's not a specific question. It's just that when you're talking about a geriatric population, I wouldn't advise anybody suggest that if they're not an athlete, it's too late, or if they can't get out and jog, it's too late, or it's not helpful. So any amount of physical activity is going to be helpful.
Thank you.
Okay, and I think Diane said that I should put this code up at the end. So I'm not sure what that was, but I did it.
Thank you. That's the link for the evaluations. There's also a link in the chat for those who prefer to click the link instead of sending the QR code.
It strikes me that the pandemic and what all of us did during the well, not everyone. Some people bought exercise equipment and exercised more during the pandemic, but a lot of people were a lot more sedentary and changed their diets in not great ways. And certainly older adults, a lot of our older adult patients, the people I'm seeing in primary care clinic have been more sedentary. So I just wonder what's going to happen in the future with these changes, and if there are any signals already happening. It's pretty early, but definitely some makeup work to do, I guess.
Yeah, and then once you have a person that's been sedentary, especially in the older years, then helping them get back to where they were before can be very challenging. And a lot of this, we look at population studies, but when you're dealing with a person, then it's population may not pertain to them. And certainly there's some people that might have been able to get out and do more, might have had more time available, but there are some people that just really they can't get out, they can't go to their silver sneakers or whatever exercise program they were trying to do because those were stopped or the person was worried about their risk. So it's all going to be variable, but I think one guideline for an older population is going to be something that we do with people with cancer. Just say, don't even try to be where you were before. Just start at a lower level and do what you can.
So, Anne, this is Steve Fleming, and in looking at your data on all of your studies, what I don't see being measured is the various lipid components that can be measured in the serum, and those all have, just coming back from AACR earlier this week, those all have significant effects on cell membranes and then responses of the increase or decrease in insulin, increase or decrease in estrogen. Are there studies where they have looked in populations with changes in exercise and diet in specific lipids like PUFAs, polyunsaturated fatty acids, et cetera?
Yeah, I think there's not much. The cancer world has not embraced the lipid world very much. There are colleagues in Norway that have looked at that, because some of their cohorts were set up when they were set up for the purpose of looking at cardiovascular disease. So they looked at overall lipids and triglycerides, and they have those measured on everybody. So this was before they did a lot of storing samples and waited until somebody got a disease to do it. They would measure these in everybody, and so along comes some of the cancer epidemiologists, and they have started to look. And I have one colleague who's looked at, I believe, breast and prostate cancer. But these are looking for just very general lipids, not specific ones. But it is a good point. We looked at one of our trials, just looked at LDL, HDL cholesterol, and triglycerides, and this was just an exercise trial, and didn't see much effect of exercise alone on that. It wasn't a weight loss trial though. But it sounds like a good opportunity for future. And we do have a lot of stored samples, so that's something we could think about.
Yep. Okay, thank you.
Thanks.
Hey, this is Angela. Can you hear me okay?
Yes.
I had to step out for a few minutes because I got paged. So I apologize if you already covered this. So I'm someone that studies diet in kind of a different way. I'm studying it in terms of how it affects our brain and cognition. But I've been kind of interested in not all weight loss is the same, and looking at like DEXA and that kind of thing in terms of where the lipids are concentrated. And is that anything that might be interesting to you down the road? Like what kind of weight loss is being sustained, and are the hormones changing that type of weight loss and all that good kind of stuff?
Mm-hmm. Yeah, it's a really important point, and especially I know things related to insulin resistance and lipids is the looking at abdominal fat. And in early trials of our exercise trials, we looked at we did CT scans and measured abdominal fat area, and did see the first signal of weight loss with exercise. So you don't lose a lot of weight with exercise. With our program, it was 45 minutes a day, 5 days a week, and then maybe they lose about 2 kilograms. For our women participants, for the men, they lose about twice that. But you do see the first signal of reduction of fat in that visceral fat area. So we did this with CT scans, and then in our weight loss trial with dietary weight loss, we didn't have funds to do CT scans on 438 women. So we did DEXA. And this is before the DEXA had the capability of measuring intra-abdominal fat. So we just have DEXA there. But one thing, it really depends. It's so important to look at the outcome that you're interested in. So since we had a great interest in these trials at looking at sex hormones, we found that the sex hormones were not related particularly to intra-abdominal fat. They're related to subcutaneous fat. And then it turns out the reason for that is because aromatase is much higher concentration in subcutaneous fat than in visceral fat. So I think it's important to think of what you're looking at. What are the biological changes of interest that you're looking at? And I think that the technology is getting better for measuring these things, and it can be done more cheaply. So we're in your trials are going to be way beyond what epidemiology can do, more than a tape measure of measuring somebody's waist. Yeah, and then you can get some information of what kind of changes, and then eventually what kind of intervention is going to get the biggest the biggest change, the biggest benefit with the lowest risk.
Right. And then to Dr. Plymate's point, I mean, if you saw those CRP changes, I mean, maybe the answers are in that serum, the lipid. I mean, you can get really fancy with lipidomics, and then hypothesis testing is a little bit out the window. I mean, you can do hypothesis testing with lipidomics, but I haven't figured out how yet. Basically, you measure everything and see what happens.
Yeah, I always find it interesting when people talk about one individual paper that's come from a study like Nurses' Health, for example, is thousands of papers. And for that one study, one paper, they want to make sure that somebody's done a bone Ferrani correction for multiple testing, but they ignore the fact that millions of associations have been looked at. So rather than just thinking about the statistics, I like to think about the biological processes that are going on, and not to ignore biology in order to chase a p-value. So, but it does become an issue of it then teasing out, and that's why you have multiple studies. You want to tease out what's a real effect and what happened by chance. Somebody else had a question in here.
It looks like
I can unmute and ask it. I was just wondering, in that study that you were referencing with your women's health, if you looked at measures of sarcopenia, especially with weight loss, because that's oftentimes what we see clinically, right? If people just diet and they don't exercise, they don't do the strength component, especially with their older, they lose the force, right? They're losing type 1 muscle fibers. And so therefore, or they're type 2, excuse me, they're type 2 muscle fibers. And so therefore that's where the balance and the strength start to decline.
Yeah, in our weight loss trial, we certainly saw that those changes, and I'm trying to remember. In one of them, you saw, I think it was the I was trying to remember if it was lean mass or skeletal mass, where it was more in one group than another, and then it flipped in the others. But there's a yeah, it was the bone mineral density where we saw the greatest decrease in those in the diet and exercise program. And they did lose the most weight, but I hope that the exercise would counteract it. Whereas in lean mass, which was non-bony lean mass, we did see the most decrease in that with diet. So just like what you said, this is what we saw in our clinical trial. In terms of what these epidemiology studies have available, it's very few, but the Women's Health Initiative was able to measure DEXA in 3 of their 40 clinics. And so for some subset of the population, there are DEXA data. Both looking at total fat mass as well as skeletal muscle mass and lean mass.
Great. Well, we're right at 9 o'clock. Thank you so much for this fantastic presentation and for answering all of our questions. It was just really wonderful to hear about your work, and this is super important to our patients. So thank you.
Thanks. And if anybody has other questions that I didn't answer, feel free to email me.
Okay, thank you. And about the slides, if Diane gets them, she can send it out if anyone wants, for everyone who wants it.
Okay.
I will put the recording of this with the slides on our website. It should be up by Monday.
Okay. Thank you.
Thank you again for coming today.
Okay. Bye-bye. Have a good day.